as a joint committee. I'm very grateful to my colleague, Chairman Rue of the Health and Mental Health Committee, for convening with us this afternoon to have a discussion about health and mental health, specifically as it relates to homelessness. And so we've structured a conversation around that. As folks know, the Los Angeles County apparatus is largely responsible for the delivery of mental health and health services. That's why we have on the Homelessness and Poverty Committee and as a part of the City Council tried to make sure our strategic plan around homelessness is in sync with that of the county. And we're pleased to have representatives from Los Angeles County represented today that will speak directly to those issues. Again, the county and the city work together in LAHSA, where the city acts as a participant, but sometimes an intermediary between individuals and services that they will later receive from the county. And so with that, I want to turn the microphone over to Chairman Rue to give a few opening comments.
Thank you, Chairman Harris Dawson. It's been a long time coming. We've been trying to set this meeting up for a while, and we will. But this will not just be our last, but our first of many. And I just want to echo the chairman's comments. You know, as we all know, the vast majority of our homeless population experiences a health or mental health issue. And whether it be domestic violence, substance abuse, mental illness, or a disability or something else, bringing these two communities together and these experts is what I believe cuts to the heart of the issue. Housing our homelessness is very important and obviously the most visible to our residents. But if we can't serve the back end, the front end, you know, and the health and mental health needs of our homeless populations, we will never get to a place where we want to be and get out of this situation, which is why I'm so happy that we're having a conversation today and look forward to the discussion and recommendations of our county departments and social service providers. So,
excellent. Thank you so much, Councilmember Rue. We'll begin this meeting with general public comment, for which we have 2 cards. And that'll close general public comment. We have Wayne from Encino, and we have Ms. Antonia Ramirez.
Mr. Chair, action to the record. Per instruction of the Chair, since the items will be taken together, 2 minutes will be given to the public to speak on the items altogether.
Excellent. So this is general public comment, and we'll go to comment on the items after this, where that instruction will be applicable.
You can take them all together, sir.
Okay. Oh, we can take them all together? Okay, you got 2 minutes, Mr. Wayne.
Okay, general public comment. So yesterday at the Police Commission meeting, as I was leaving the building, Vice President of the LAPD Commission, Steve Soberoff, came to me in the hallway directly near the area where I was illegally arrested November the 10th.
My apologies, Mr. Wayne, and we'll actually restart your time. So we are taking public comments for items 1 and 2. So you have to comment. You have 2 minutes in which you can comment on either item 1 or 2 or both. Your time starts now. Thank you.
You were allowing general public comment, you said.
I'm rescinding my call, clarifying my call.
No, he said that was going to be separate. General public comment separate from the 2 items. Yeah, but there wasn't a vote. There wasn't a vote by.
Since the items will be taken all together, it's the instruction of the chair for the public to be given 2 minutes to speak on all the items, including public comment.
So the structure of this meeting doesn't require us to have general public comment, and we're not going to have general public comment. You will have 2 minutes to discuss items 1 and 2. Your time starts now.
So, because of Gil Cedillo, wants to talk about homelessness. Well, let's talk about homelessness, and let's talk about CD1 and what's going on in the school zone between James M. Wood Boulevard and 8th Street, and how this man is allowing Coronado between 8th and James M. Woods and Hoover between 8th and James M. Wood to be populated by a shanty town, the worst fucking thing we've seen since the 1930s Depression. Absolutely disgusting. Elderly people at the senior centers who are Korean Americans and veterans cannot walk in that area. Women with children cannot walk there. It's not safe. And over by the Silver Platter on 7th and Rampart, there's a prostitution ring going on there each night. Under Ed Reyes, you could call 311, you could reason with Mr. Reyes. But now with this new dictator, Gilbert L. Cedillo, you can't. Now it's a whole shanty town. Because we've got people, Asian Americans, Korean Americans, who always get discriminated against, that cannot do their lawful business because of this shanty town selling drugs, prostitution, bottle companies, taking junk cars and using all of the parking up, and these people are terrified. And we've had LAPD come out, we've had city come out, and they're like, well, you have to talk to the council office. Well, we know about that. We all know about the council office because LA is divided up into 15 kingdoms. There's 15 kings. Well, 1 queen and 14 kings, but you get the point. So we need to take care of that. Get the shanties out. Shanties are not homeless people temporarily sleeping on the street under the Ninth Circuit. This is a shanty town. It's a public safety destructive issue, and it needs to be resolved right now.
Thank you so much. Ms. Ramirez, you're next. After that is Mark Casanova, Monica Quezada.
Thank you. Being a victim of gang stalking crimes and homeless is sheer torture. And because I am homeless by political design and retaliation, it constitutes cruel and unusual punishment. We are stripped of our fundamental basic rights to be human and free with life, liberty, happiness, and the right to our property, as we legal law-abiding citizens are promised in the United States Constitution. Furthermore, for those of us who are not alcoholics, nor drug addicts, nor violent offenders, physical brawlers, we are mob lynched every day and night by other violent homeless junkies, wetbacks, chango wetbacks, and gangbangers, chango Latino gangbanging pussies, because that's what they are, and pimps and drugs and bullies. They use brute force against us on a daily, but mostly nightly basis.
You got to stay on the subject, Ms. Ramirez.
Okay, we're talking about torture, mental issues. And that's why we come here, because that involves mental issues. You get angry because you get deprived of the right to be free, even when you're on the streets. That's mental issues, okay? You have to tackle on these goddamn wetbacks and gangbangers and blacks every single night. That's a mental issue. Who helps us? Nobody. Nobody, not even you. So our military veterans have paid hell out there. So having said that, again, we ask you, ladies and gentlemen, we are subjected to theft, vandalisms, assaults, and because we're deprived of safe and secure bathrooms, showers, storage, and places to eat 24/7. So I ask the mental health providers, Department of Social Services, and all health welfare services, your homework assignment is to Google search retired ex-FBI agent Ted Gunderson. Again, retired ex-FBI agent Ted Gunderson on YouTube regarding gang stalking, homelessness, and mental issues. He's very descriptive and very profound about mental issues. Ted Gunderson, and he will outline it for you, and he will explain in detail, and that's why I'm voting for God bless.
Thank you. Mr. Casanova? Ms. Quezada?
Welcome to me. I want to talk a little bit about homeless health care, and I'm here to talk about just supporting not only the motions, but the work we're doing, trying to work together, being more collaborative. I think I'm hopeful that, yeah, we keep moving forward in that direction. Homeless health care has been around for about 30 years. We do behavioral health care, housing, and harm reduction type programming. And what I'm really here to talk about is a specific gap. I wanted to talk that when we do create these plans, that I have 4,000 injection drug users that filter through annually through a site in Skid Row. and they're a very difficult population to work with. I do get City of LA, City AIDS Coordinator money. That's really fabulous. But this is a group that's affected by at least one or several public health issues: HIV, HCV, and death. Every time an injector injects, they risk death from overdose. So today I'm here to say that if we do create a plan, let's make sure that we attach strategies that address overdose and treatment. The president recently spoke about overdose problems and talked about MAT services, which are replacement therapies for a heroin user. Those types of programs we need to promote, so I want to make sure we include those. And a drug called Narcan that reverses an overdose. Every worker that does outreach, everybody that comes in contact with anybody that injects drugs should be helping that person access Narcan. It'll save a life. And we can't put a dollar value on what a life saved costs, but my group has saved about 700 over the last 4 years. And it's a fact we're really proud of. So just to encourage you to make sure that in the strategies we do that. And I'm going to cut it to Monica because we want more time.
I have 10 seconds, and I just want to say thank you, Councilman Cedillo, for all the support that you've done through the coordinated entry system. We have been able to successfully remove barriers in working with homeless individuals. I see the only thing I do want to address is some of the gaps that we have very limited DMH mobilized teams. They're doing a fabulous job of actually opening up cases on the street, and if we can increase more of those actual teams out there, we'll do more fantastic work. Thank you.
Thank you. We have Lakeisha Childers and General Jeff.
For the record, Councilmember Huizar and Councilmember Fuentes has joined us.
Just for the record, Councilmember Jose Huizar and Councilmember Felipe Fuentes is present.
Okay, good afternoon. Thank you for this opportunity to speak. My name is Lakeisha Childers. I'm here on behalf of PATH, People Assisting the Homeless, and my comment pertains to the provision and coordination of mental health and substance use services. We continue to have difficulty accessing services for our vulnerable clients in both the areas of substance use and mental health. The appointment system for mental health services does not work well with the vulnerable populations that we serve. Appointments are often set too far in advance and clients are unable to keep them. This sets the cycle of no-shows and case managers have to work harder to help them gain access. As it relates to substance use services, there are not enough treatment beds, especially following the detox process. In both instances, these are key times with clients, and we want to be able to capitalize on that. When someone agrees to an assessment or treatment, making them wait does not lend to successful intervention. In all, we're hopeful for a stronger coordination and more flexibility with the individuals that we serve. Thank you.
Thank you so much. That concludes public comment for this meeting. Mr. Clerk, we'll be taking, oh, I'm sorry, General Jeff. I'm sorry. Come on up. Quick, come on up. You were hiding behind the pillar.
Waiting for a dramatic entrance. Good afternoon, both committees. My name is General Jeff from Skid Row. Happy holidays to all. Unfortunately, in Skid Row, while there are a lot of folks that are caring and loving on our community, there's not a lot of happiness to speak about in regards to mental illness. I imagine you're going to hear a lot of wonderful presentations about the services that are provided to my constituents and my fellow residents in Skid Row and across the city of Los Angeles. What's being omitted is our perspective from the conversation. So let me lay it out there for a lot of people that really don't understand. Let's say there's a fast food establishment that only serves one type of burger. Technically, they can say they provide food. That doesn't make it quality food. That doesn't make it good food, and it doesn't make food that the people want. So because people don't go into that fast food establishment, you know, why is all the blame being put on the people? And these two committees need to hold these service providers more accountable, meaning let's get into the specifics. You know, just because they provide mental health services doesn't mean it's quality mental health services. Exactly what does that mean? Is that just lay on a couch and just talk for hours while I take notes and a summary of what your life is about? That's not quality mental health. How can we make mental health services for the city of Los Angeles better? That's that's the task that you all have, and that's where the failure is. We need to hold these people accountable for the so-called the services that they provide, because right now there's a lot being left and a lot being overlooked and a lot being omitted, and who's going to hold them accountable? I'll waive the rest 15 minutes of my time. Thank you.
My apologies again for overlooking you. We want to move quickly into our conversation. We have representatives from Los Angeles County, and we want to tee off the conversation with a brief overview by leadership from LASA, Mr. Peter Lynn, and with him I will call up from the CAO staff, Trina Unzicker, along with Los Angeles County reps. And if the two of you will provide us with a brief overview, and then we will hear from the individual departments.
Mr. Chair, would you like me to read the item into the records?
Yes, sir, please. Both items.
Item number 1 is a verbal presentation from the Los Angeles County Departments of Mental Health, Social Services, and Health Services relative to the services provided to homeless individuals. While item number 2 is a motion from Council Members Rue and Harris Dawson relative to the access and availability of mental health and substance abuse services vital to serving all neighborhoods and residents of the city.
Thank you.
Good afternoon. Trina Unzicker with the Office of the CAO. In the spirit of discussing the ongoing efforts between the county and the city to serve the homeless population, I wanted to give you a brief overview of what the city and county have been working on together over the last few months. We've been participating in meetings together that are collectively called the Homeless Initiative. The Homeless Initiative was designed to help both the county and its cities, including the city of LA, generate a coordinated set of strategies to better manage homelessness issues through an intensive and inclusive planning process. To develop those strategies, 18 policy summits were held between October 1st and December 3rd, including 2 summits on each of 9 topics. The policy summits brought together county department representatives, City of Los Angeles representatives, representatives from other cities, the Veterans Administration, nonprofit service providers, community stakeholders, and subject experts. I'll just briefly summarize the 9 topics around which the policy summits were structured. We talked about Affordable Care Act opportunities. As of January 1st, 2014, almost all homeless families and individuals qualify for full-scope Medi-Cal, including mental health and substance use disorder services. We discussed coordination and integration of current services and no wrong door. For example, one of the questions we discussed was, should there be a standardized countywide response to homeless families and individuals? One of the topics was discharges into homelessness. Many individuals previously in the prison system, foster care, or hospitals are homeless upon a discharge by a county department or from a city jail. For the topic of employment, we discussed what additional efforts should be undertaken to help unemployed homeless individuals, including parents, secure employment. We discussed encampments, street homelessness, and the outreach and engagement that's necessary as a result. For example, how should encampments and street homelessness be addressed? Homelessness prevention, what actions could or should be undertaken to reduce the number of people who could become homeless? Land use, should land use policy be modified to encourage increased affordable housing, for example? Subsidized housing, what opportunities are there to increase subsidized housing? And finally, supplemental security income, otherwise known as SSI, and veterans benefits advocacy, resulting in the question, would a coordinated countywide approach that incorporates the city to benefits advocacy enable more disabled homeless individuals to qualify for SSI and veterans benefits? So just to summarize, more than 20 county departments work together with counterparts from our city and other cities, other government agencies, and community stakeholders to look for ways to leverage funding and programming opportunities to build a system that combats homelessness in a coordinated fashion. The representatives before you took part in these conversations and have come here to offer their expertise regarding the issue of homelessness with you. They will describe the county services as they relate to homelessness and continue this collaborative effort with your committees. Maria Funk is the Mental Health Clinical District Chief for the Countywide Housing. Maria will be presenting on the approach that DMH has taken to ending homelessness by developing mental health services programs that target the homeless population and increasing housing and related resources to end homelessness. Cherie Todorov is with the County Department of Health Services Housing for Health and will be talking about interim and permanent supportive housing programs and how they link together rental subsidies, housing, and intensive case management services to support housing stability. And Jose Perez is with the Department of Public Social Services and will present on current services that help homeless individuals and families. DPSS administers the California Work Opportunity and Responsibility to Kids, which is CalWORKS, CalFresh, Medi-Cal, General Relief, and in-home supportive services programs, as well as the cash assistance program for immigrants to low-income residents of the county. And of course, we also have Peter Lynn here, who is representing LASA.
Good afternoon, sir. Peter Lynn, Executive Director for the Los Angeles Homeless Services Authority. Our role in this planning process has been both providing strategic collaboration and staffing into the process. We've provided analytic support and a lot of data, but we also, as the Joint Powers Authority responsible for administering federal and local assistance, with some state assistance added in there, we are closely collaborating with the agencies at the table as well as numerous other partners to build out an infrastructure that is responsive to the needs of the population experiencing homelessness in Los Angeles. The depth of suffering in this community is profound, and there are many people who our demographic survey resulted in finding were experiencing serious mental illness, were experiencing substance abuse addiction, were experiencing physical illness. So we had a very high percentage of people who fell into all of those categories. We had about 30% of the population that fell into a category of and these are self-reported numbers. These are people with serious mental illness, about 25% with substance abuse issues. So it does cut across the entire population that we're serving. The services that are delivered by the county are also linked to a collaborative framework that is being built out as an infrastructure to serve all persons experiencing homelessness, which is a coordinated entry system. So each of the partners here has a role in engaging with that and with contributing into resources, and particularly health and supportive service resources into that infrastructure, and they all have a role in terms of pulling people out of homelessness. There are a number of new resourcing opportunities that are coming up very, very shortly. One of them is a Medi-Cal Medicaid waiver. So the Medi-Cal has applied for a federal waiver under the 1115 section of Medicaid. It permits the use of a wide latitude for the expenditure of Medicaid funding. The application that was put together should permit the kinds of supportive services that are necessary but that are not direct mental health or substance abuse or physical health treatment. Kinds of ancillary supportive services which are challenging to pay for should allow Medicaid funding for those services, which would be a tremendous increase in our supportive service capacity. In addition, California just permitted a drug Medi-Cal waiver, which should provide tremendous expansion to our ability to provide substance abuse treatment services. So both of those we're on the cusp of tremendous new opportunities to leverage federal supportive services and drug treatment services for this population. I did not prepare a visual. I don't know if my colleagues did, but I will. I'll turn it over to. Which one of you wanted to go first?
Good afternoon. It is afternoon, council members. My name is Jose Perez with the Department of Public Social Services. There's a variety of homeless prevention programs and assistance programs that the department provides. I think one important starting point is to kind of chunk this up into the types of populations we can serve, because there are limitations in the services that we can provide. Obviously, there's families and individuals, but within families, and starting off with the CalWorks program, there's families that are not eligible or not engaged in welfare to work opportunities. Homeless services for those families are relatively limited to once in a lifetime temporary homeless services up to 14 days and permanent homeless assistance to help them stabilize. That's the limitation on the overall CalWorks family when they're not engaged into welfare to work opportunities. When they are engaged in welfare to work opportunities, which is what we really encourage, obviously, and mandate, there are quite a bit of additional services that we can provide. Under state guidance, the state allows us to basically say this is a barrier to employment, therefore we can provide additional homeless services. This involves homeless prevention services dollars, moving assistance dollars, which includes things like deposits for utilities and last month deposit, these kinds of things. We also have additional temporary housing dollars that we can also provide. So again, the key here is that if we're able to engage them in welfare to work opportunities, there's quite a bit more that we can do. But again, it does limit the number of families that we have. We have a number, obviously, over 30 district offices out there, and we can engage folk that way. But we also have the partnership with LASA and various department counties, including those here, in which we're out in the various communities to try to engage homeless families in the Homeless Family Solution System. That's important for us because while we do what we can and have quite a bit of resources, the professional services, the linking of really truly assessing and assessing a family's needs, that's critical. That's a critical skill set that our department does not have. So having partners like LASA is extremely important, so we can link our participants with additional services. So that's the family side. On the individual side, on the single adult side, this is a county-funded program, so the resources are relatively limited. We have an general relief emergency housing program. It's currently more based on daily rate motels, so we are transitioning away from that, and again, partnering with LASA to be able to move towards a shelter-based program. So we're very excited about that transition, and it is temporary. It is the way it's designed right now. It's not the strongest system in the world, but having LASA's incorporating LASA's coordinated entry system into the process would be extremely helpful for us downstream. We also have a very limited but very effective rental subsidy program for single adults, and that's been very helpful in stabilizing individuals. That's the extent of what we can do for our single adults. But again, with the homeless initiative, we're very optimistic that we can expand beyond that. And the years we've had in experiences with these programs and these populations are extremely helpful, and we can inform that process. The opportunities that we have, and talked about it a bit here, is we also administer the Medi-Cal Program. So through Medi-Cal outreach, we're engaging folk not just for their physical health, but as discussed earlier, there's also the option to the ability to cover mental health treatment, substance abuse treatment, as well as other opportunities, and really looking at the individual's holistic needs in terms of health. So there's opportunities there that we're happy to partner on. And even on our CalFresh program, CalFresh provides benefits for individuals to address food insecurity, but there's even for our homeless individuals, we have a restaurant meals program in which participating restaurants can participate in offering prepared meals to homeless individuals as well as elderly. We're incorporating healthy options related to that. So there's a number of things that we're trying to all coordinate and tie into, not going away from just being a cash-based kind of social service programs to service-based and really leveraging our partnerships. So there's a number of things we could go on and on about, but I think it's extremely helpful to hear about from the mental health and health side of things, of the really creative things that they're creating in addressing this problem.
Hi, good afternoon. I'm Shri Todorov, and I'm with the Department of Health Services with Housing for Health. And we operate the public health healthcare delivery system here in the county. And as part of that, we serve approximately 600,000 people each year, and many of those people are homeless. And so what we have seen is would be sort of a revolving door of people who are homeless and who are very sick, who are coming through our emergency rooms, and who we take care of the immediate reason why they came in. But that is not a long-term solution. When they go back out into homelessness, it's very difficult to take care of a wound or to maintain your medication regimen or to recover. And so people would cycle back through again. People were not getting better, and it was not a good use of our healthcare delivery system. So that is when we came under, we created under the direction of our director, Dr. Mitch Katz, Housing for Health. And our vision under Housing for Health is to create 10,000 units of housing connected to the healthcare delivery system to serve people who are homeless and who have really complex health and behavioral health conditions. The main body of work that we do is permanent supportive housing. To date, we have assisted about 1,100 people into housing. We are on pace right now to get that number to about 2,500 by this summer. There are three main tools in our arsenal, our toolbox basically, that we work with. That is rental subsidies, housing units, and what we call intensive case management services, or all those wraparound support services. So on the rental subsidy side, we have been very fortunate to have really good partnerships with our housing authorities, particularly the City Housing Authority, and have a great relationship to partner on using those federal rental subsidies such as Section 8 and project-based vouchers and Shelter Plus Care to target them to this most vulnerable population. And what we bring to that is the wraparound of all of the intensive case management services. We are serving of those 1,100 people to date. About half of them have been housed with these federal subsidies. The other half have been housed using a rental subsidy that we created locally called the Flexible Housing Subsidy Pool. And so that is right now primarily Department of Health Services dollars, but has included investments from the Hilton Foundation, from probation, from the Department of Mental Health as well, from working with DPSS and the Board of Supervisors to serve GR recipients. So with that flexible housing subsidy pool, which is operated by our sort of housing intermediary called Brilliant Corners, they have brought about half of the housing subsidies to the table so far with the clients that we've housed, and that has given us a tremendous amount of flexibility. And so for us, as we were looking at the number of clients we were trying to serve and help into housing, and we were looking at the availability of the federal subsidies and realizing that was not going to be enough, and in addition, some of our clients were just not going to become eligible for those subsidies. We did turn to the flexible housing subsidy pool to help close that gap and to give us flexibility to get into different types of housing as well. So that's the one big piece is the rental subsidies. The number two thing that we have that we work with is, the housing units itself. We're very flexible on housing. We work with housing. Quality is important to us, but other than that, we're very flexible. So we do everything from permanent supportive housing to affordable housing to market rate housing. We have everything from a single family unit to a 100 unit completely dedicated to housing people who used to be homeless to another 110 units in a 400 unit building that also has, affordable housing and market rate. So we're very flexible with this. That has allowed us to secure housing countywide in a number of different communities, in a number of different settings. And then the third piece of it would be the intensive case management services. And those are the wraparound services that are matched to every client that goes into housing. With that, we have a great group of partners that we work with, over 20 of them that are established homeless service providers. We contract with them to provide those services. There is not a dedicated funding stream for those services, so we pay them to provide those services. They stick with the clients for as long as the clients need that support, and they do everything from linking to health, mental health, and substance use services to assisting with establishing eligibility for GR or SSI or Medi-Cal benefits, looking at vocational and employment opportunities, everything that the client may need to help them stay stable in housing and to support them. The outcomes so far have been very good for us. We have about a over 95% housing retention rate for clients who, after 12 months after they've gone into housing. I think a key part of that would be the intensive case management services and the wonderful providers and case managers who are working with the clients. And on the hospital side and the healthcare delivery side, we have seen big reductions in use of expensive healthcare resources. So like a 77% reduction in ER visits, 85% reduction in inpatient days. And a key piece of what we're doing is getting those clients connected to a primary care medical provider. So that's where they're getting their healthcare and helping with management of any conditions and not going through the ER to get those services. Thank you.
Hi, I'm Maria Funk from the Department of Mental Health, and with the stats that Peter gave, we know that DMH plays a big role in helping in homelessness for people with mental illness. We've employed two strategies, basically, and one is to develop programs that target people with mental illness, and the second is to develop housing resources to help them get permanent housing. So I'm going to talk about these two strategies, and there's a lot of different things we're doing, so I'm going to highlight three programs that we have. They're service programs, and then talk about the housing resource side. So on the service program side, I want to start by talking about the Integrated Mobile Health Team. And we created these teams in 2012. They were pilot projects, and at the time we thought they were very innovative because it was before the Affordable Care Act when we developed this program. And basically the idea is the integrated team provides health, mental health, and substance use services all as one team. And we used a street-based medicine model. We leveraged federally qualified health centers because each team has a federally qualified health center partner. And basically the teams went out and targeted and outreach to and engaged people on the streets who are considered most vulnerable, people with comorbid conditions of mental illness and at least substance use or a serious health condition. And we had 5 teams countywide, and we did a very extensive evaluation of these programs through the University of San Diego. And we definitely found there were significant results in terms of improvement in health, in their health, improvement in the mental health, reduced use of substances, and including alcohol and drugs when we assisted people through this program. And obviously one of our primary goals with this program is helping people move into permanent housing. And so like I said, it was a pilot project because we used MHSA funding that was from our innovation programs, which are time limited. And so based on the evaluation, we determined which programs we were going to continue with. So now we have 3 programs for the Integrated Mobile Health Team countywide. They are located in Skid Row and South LA. That's one team. Covers both areas in West LA and in the Service Area 8 area, including Long Beach and San Pedro down there. So I also want to highlight a new program that we have, which are called the multidisciplinary integrated teams. And these teams were really modeled after the IMHTs in some ways. They don't include an FQHC partner, but they do have a health partner. So the word integration, again, is meaning that we are providing health, mental health, and substance use services. These teams started in June 2015. And they're innovative in the sense that we took funding that we, DMH, have received for years called PATH funding, which is from the federal government, and we combined it with the county's homeless prevention initiative money, and we developed a program. And if you've heard of the county's single adult model, this is one component of the single adult model, which is a model that we've developed in the county to serve people who are homeless, who are single adults. And so through this program, we target, again, people who are homeless and considered the most vulnerable. We have the teams, which, by the way, we call them the MIT teams, if you've heard people use that term. We have teams in every service area in the county, in all 8 service areas. And each team, these teams there's a lot less funding for this program than the IMHT teams have. So their staffing is less than those teams. But each team has a core staff of 5 people, including licensed mental health staff, case manager, a peer, a substance use counselor, and a part-time psychiatrist. And the other collaboration is with DHS, and they provide a nurse on each of the teams. When we brought these teams to the board for funding, to get approval for funding, they did a motion that they wanted us to expand the teams in the parts of the county that have the highest homeless counts. So we did expand the teams in service areas 2, 6, and 8, and then they also wanted us to have an additional team in Skid Row. So we did do those expansions, or we're in the process of those expansions. The Skid Row team is just starting now, actually. The MITs use, basically the model is, again, doing outreach and engagement to people who are homeless, helping them move into housing, and then they're using an evidence-based practice called critical time intervention to support people when they move into their own homes to help them successfully stay there. And actually, so obviously we can't be successful with that model without housing. So I just want to say that our housing for that program is through 2 contracts, new contracts that we have with the city, the HACLA and HACOLA, the County Housing Authority, that we got through last year's Supernova, and they provide shelter plus care. So we'll be using those resources. We have 93 from each housing authority, and then also we have some funding through what Cherie talked about, the flexible housing subsidy pool, that will also be supporting some people and subsidizing their housing through that program, the MITS. So the last program I want to talk about are our new, what's called the SB 82 mobile triage teams. SB 82 is obviously the legislation that was passed to provide funding for that program. SB 82 is a statewide program, and in LA we have several different programs that are funded through SB 82, but the mobile triage teams are specifically, again, targeting people who are homeless, veterans, and older adults. And we have this team countywide, so there's one team in each service area. They are directly operated by the county, and their job is to be in the community, to outreach, assess, and actively link those who are homeless into services, and then, of course, to help them move into housing. We developed this program in response to the community and getting feedback that it's very hard for people who are homeless to come into our clinics, to access services. There's a lot of barriers, so we wanted teams in the community that could directly work with people in outreach and do the assessments in the community instead of expecting people to come into our clinics. These teams they just started this year, and they're still staffing up for the most part. Some are fully staffed. Each team has about 9 staff in the service areas, and they also have stipended volunteers that are people who have lived experience with mental illness. That's a big part of SB 82, or hiring people with lived experiences, and that's across the state. These teams work under our service area administrations with our other service area navigators and our other housing specialists that we have, so we can really have an integrated and coordinated services in the community. So our other strategy, like I said, is increasing housing resources. And so we have a temporary shelter program. We have a housing assistance program, which provides security deposits and household goods and eviction prevention to our clients. But I'm going to focus on our permanent housing resources. So we've had a long-standing relationship with the City of LA, HACLA, their housing authority, and HACOLA, actually. So currently, DMH has 1,961 certificates and vouchers through the 2 housing authorities, including Shelter Plus Care, Section 8, the Tenant-Based Supportive Housing Program, and 1,516 of those are through HACLA. So, and we've had some of those contracts since the 90s, but we've had a huge infusion actually this year of these resources, which I'm going to talk about. So last year through the Supernova, there was an opportunity for the continuums to apply for what was called the bonus, and it was a nationwide competition. So HACLA asked DHS and DMH to partner with them to apply for that, which we did, and actually we were awarded, and it was bringing in 10 million new resources into LA, into the City of LA through the bonus. And the program started in October this year, just a couple months ago, and again, targeting chronically homeless people with the highest acuity, referred through the coordinated entry system, that are receiving services through DMH and DHS. There's 547 Shelter Plus Care certificates through that program, split between the 2 departments, and about $2 million for supportive services. So it's a unique Shelter Plus Care contract because it includes money for services. So we're leveraging DHS's contracts they have with their intensive case management services contractors, and they're going to provide the services to the clients, the housing services. DMH will provide the mental health services, and DHS will provide health services, providing the in-kind match that's required for the program. So the last thing I'm going to talk about is our Mental Health Services Act housing program, and this is the program that we have that it allows us to invest in building permanent supportive housing. That program provides capital and operating funds for the development of new permanent supportive housing. And this program started in 2007. It's a statewide program. In 2008, DMH, LA County, invested $115 million into that program. Through additional investments from 2008 to today, we actually have $145 million now invested in that program. We currently have 46 projects across the county of permanent supportive housing, 30 of which are open and occupied. Those 46 projects represent 1,011 units of permanent supportive housing for people with mental illness who are homeless. The projects target all ages, families, transition-age youth, and older adults. And right now we have approximately $19 million unallocated. So obviously we will be growing the portfolio as we dedicate those funds to new projects. Many of those projects are in the city of LA and also include HACLA and HCID resources. And we work very closely with them on the development of those projects. And we have an MHSA Housing Advisory Board that reviews all applications for this funding and makes recommendations to the department about which projects we should fund. That includes on the advisory board a member from HACLA, one from HCID, and Peter is on from LASA. And actually, Cherie is on from DHS. So where we come together and review the projects and make decisions about investments. So I'll stop there.
Thank you very much for that great presentation, and I'm sure those who are hearing this committee meeting are probably thoroughly confused with all the acronyms and all the dollars that were thrown out. So I mean, I'll open it up with a few line of questioning to kind of synopsize this. But I really want to thank the leadership of the Department of Mental Health, partially through the Mental Health Services Act. And for my colleagues and for the public who's hearing, the Mental Health Services Act passed close to 2004, right? 2004. And now I believe it's a 1% tax on people who make over $1 million. That generated close to $1 billion statewide. And for the Department of Mental Health, LA County Department of Mental Health, about $300 million now or whatnot. And with that money, they leverage other federal and other different sources of funding to grow their department from, when I was working for Supervisor Burke in the county, the Department of Mental Health budget was $1 billion. Now it's grown to $2 billion in the past 10 years. So, and that's what we're talking about. And again, the health department with the new director, Mitch Katz, I mean, it's amazing what he's done, in particular expanding the definition of what health is, to include housing, to include homelessness. I mean, to include all of this. I mean, it's something that academia has been talking about for a long time, and the health department is a $4 billion budget. So just by the representatives here in front of us, LA County Department of Mental Health is about $4 billion. Department of Public Social Services, $3 billion. Department of Mental Health, $2 billion. And Public Health, who's not represented here, is about a little less than $1 billion. So these departments added together, their budgets to tackle this problem is equivalent to the city of LA's budget. And which is why it is so amazing that we're, for the first time, working together. Not for the first time, I'm sorry, but working together to work on this process. So a question I had, one of the first questions I had was, what's the status of the county's consolidation of the Department of Health, Mental Health, and Public Health? Can anyone?
Well, I can say from the the homeless services and housing side that we are bringing our three departments together to specifically look at that issue and how we can integrate and make sure we're leveraging all the opportunities available across our departments, and that is sort of like a seamless experience for the clients that we're serving. And so they're not experiencing that they're being bounced around or they have to go to a different place to get access to support services or clinical services or housing services. So from the homeless services side, we are starting that process of looking about how we do all of our coordination and integration and leverage all the resources to make it a comprehensive system for the clients that we serve. You know, on the larger sort of clinical service side, I am not the expert on that side. I know the departments are definitely working together, looking at how to integrate clinical services within the same settings or to share information across providers so that clients are getting the best possible care. So the mental health provider knows is working with a physical health provider to best coordinate the care for the clients. I don't know, Maria, do you have anything to add to?
Not really. I mean, it's new to all of us, and it's just, I think Dr. Cass was appointed just a couple weeks ago or a week ago. So we are having various committees to meet, like Cherie said, and one of them is regarding homelessness, to figure out how we can streamline and work together and make the processes easier for the clients that we serve.
It's going to be it's going to be a smoother, very smooth process, I think, because something that we've been doing over the last several years, even before this happened, is exactly doing that type of coordination. We're working together so closely to serve our homeless clients.
Great, yeah, and I was going to mention that even before the consolidation of all the departments in the county, with Phil Ansell, you guys were already working on coordinating together with not just the county, but with the city as well. And the different service providers. You know, I want to bring it down to a very low level level where actual folks could understand this. Can you give me an example, like when it comes to housing? You could tell us how it's working now, and or if you have it with the whole discussions with Phil Ansell and the whole consolidation, how you guys are looking at it. Because we just heard about the many programs that health department does, the public DPSS does, as well as mental health. And of course, the city, we have our housing authority as well. Can you, from a provider standpoint, I mean, having worked both at the county and also at one of the largest mental health and homeless providers in the county, how do they navigate all these different funding streams? How does all this come together? Give us a little example.
I think as it relates to housing, because of the coordinated entry system, it makes it easier from a provider standpoint, because when the providers on the street are working with someone who's homeless and they're using an assessment tool to assess them, to assess their acuity level and assess their need for housing, the type of housing they need, and entering it into a system or a database, if you will, and then we, DMH and DHS is doing the same, you know, we have housing resources that I talked about. So when we have housing resources available, we let the area where the housing resource is available know that we have the housing resource, and then they look for the client with the highest acuity and match that client to our housing resource. So from a provider level on the street, they don't have to go to DHS, can we use your resource, or DMH, can we have your resource? We have now a system that people can go to and get matched to whatever resource comes up that might be the most appropriate one for that client. So I think that does help the system in some ways avoid some of the, you know, for the providers and for the clients of having to try to figure out, you know, and apply for every resource out there instead of doing it through a system.
So actually, that's my secondary question, because I think that was more for a client perspective. If we identify someone in our areas, in our neighborhoods, who can qualify for this, you know, it's about figuring out who to contact. You know, whether it's the provider or the county department, and it's having that hotline number or that agency that we could work directly with. In my district, in my office, we work with a lot of local providers. But then I was talking more about the funding. So if PATH or any one of these agencies that are here today, special services group for groups, are trying to build additional supportive housing, you know, it's kind of like a free-for-all where they have to navigate on their own, trying to piece all this together. And I wanted to see if you guys are working on making it a little more simplistic system to help build these.
Yeah, I would say say certainly on the capital development side, which I'm not sure how much you're talking about that is a very complex issue, and Maria's much more familiar than I am. But I can say sort of one of what we're trying to do with Housing for Health is for all of the clients that we're serving through that program, we're trying to eliminate all that complexity by providing all of the resources to the service provider. So we are providing the funding for the case management services, so they're able to hire those case managers and social workers to work with a client, and we're also providing the rental subsidy. That rental subsidy could be coming from a number of different places, depending on what the client's eligible for and what we have available at that time. But we're giving that to the service provider so that they can do the case management and they have the housing subsidy, and even the actual unit itself happens in a couple of different ways. Sometimes the case managers or those agencies are out working with the landlord networks that they have to secure the housing, but also we are out there finding housing as well. So we could say, hey, we have these properties available or these groups of units that you can tap into if that's one of the places where your client might want to live. So we're trying to bring all of that to the table in a package for the Housing for Health clients to make it easier to navigate.
Really quickly, thank you for allowing me to interrupt you, Mr. Chairman. I just want to take a moment to release Peter Lynn from the table here. We took some votes today on council. That means there's some contracts you need to get signed, which you can't do at the table. So please pardon me, Chairman, for releasing him at this moment.
Thank you, sir.
And I want to give opportunity for my colleagues to ask a lot of questions as well. But so my whole thing is while we're at this opportune time, and this issue is not a new issue. It's been around for years and decades. And I remember when I was at the county over 10 years ago, this issue was front and center, and there was a lot of finger pointing. The county telling the city, you're not doing what you're supposed to do. The city pointing the finger to the county saying, you're not doing it. But today, the issue hasn't gone away. It's actually gotten gotten more significant. But this time around, the difference is the county on your own. Well, you guys are already working to be collaborative and not working in silos, working together with Phil Ansel and all these things that you're working on. But more importantly, we're working collaboratively with the city. I know my colleagues, especially on the homeless committee, has been working closely with Phil Ansel and the county. But it's not just city and county, but it's also the state and the feds who are all recognizing this problem and trying to figure out how we could work together on this. And I think this is a very great opportunity to be able to merge all our resources. So, my whole thing is, at the end, I would love to see an integrated system, not just amongst the county family, but with the city. Like I mentioned earlier, just the departments on the table here rival, if not, is larger than the city of LA's budget. We can't solve this homeless issue on our own. So it's about where can the city help and not duplicate services, not keep on spinning our wheels. I mean, it's as simple as whether it's from a provider who's trying to build more supportive housing and we want to support, it's how do we help them leverage county resources and city resources to get that built. More supportive housing, shelter beds, whatever it is. Creating like a hot sheet, even for my office when we have homeless encampments. The fact that we have to try to track around and see who we're supposed to call, which agencies can we call, which departments can we call. It's about, I having worked in the county, I have a lot of relationships, but it's not just for myself, but it's for everybody in the city, where we don't have to contract out with one of the providers you're already contracting out to do this, to deliver the same services that they're already doing. So it's about how do we integrate these things, coming up with, some sort of hot sheet for all the different service areas, the spas, in conjunction with the city council districts, so that we could help city folks on who to call, how to coordinate. So I'm really encouraged by everything that we're doing. And with that said, I want to open it up to my colleagues on the mental health committee. Any questions?
Sure. Thank you. Thank you, Chairman Rue. Thank you, Chairs Marquise Harris-Dawson and Huizar for this joint committee hearing. I think it's really important. And thank you for the wonderful presentation of this panel. I'm going to have a few questions, but just one point of clarification. Ms. Funk, the last program you mentioned was mental health services blank, blank, blank started in 2007. I just didn't catch the rest of it.
It's Mental Health Services Act housing program. That's what we call it statewide.
Right.
And that's our capital development program.
So one of the questions I have, and I'll just ask a few now and cede the floor and then maybe come back. And then Ms. Todoroff, you mentioned the Intensive Case Management Services Program. I'm curious to see how many clients you have within that program in the county.
So every client that we assist into housing is receiving intensive case management services. And so right now we have approximately 1,100 clients that we've assisted with housing. So all of those clients are receiving
1,100. And is there crossover with this program to some of the programs that were mentioned and the teams that interact? For example, the multidisciplinary integrated team. Do they work within this intensive case management services program?
And so there is some of the teams that Maria was talking about, they are really out on the street and doing street outreach and engagement and doing that first step of helping to get somebody connected to services and housing. And the intensive case management services that I was talking about, they also do some of that work, but what they do is they stay with the client in the housing as well. So they continue to support them through getting into housing, finding a place to live, getting IDs so you can complete forms, filling out Section 8 applications, signing a lease, all that kind of stuff, and then helping them get connected to their income benefits that they're eligible for or their health benefits, and then staying with them indefinitely into the future. And so that's an ongoing resource that stays with the client into housing.
And what do you imagine is the greater universe of need beyond 1,100 clients for this particular intensive case management services program?
Yeah, and so, certainly it's a good fit for most clients who are chronically homeless, those who've been homeless for a while and who may have a complex health or behavioral health condition. That's the population that we're focusing on ourselves, and that is a model that has been very successful with that population. So looking at the population of chronically homeless in our county, that would be a fairly good match for who could benefit from the housing resources and the intensive case management services.
And although anecdotal, it wouldn't be a stretch to say that we need thousands and more individuals into this program. Yeah. And I know that homeless populations differ in across the city and across the county. I know that the homeless encampments in my district it's way above 25% in terms of addiction issues and mental health issues. And I imagine a world wherein the majority of the individuals in the encampments that I visit are in need of this intensive case management services. And with that comes the whole quandary about how do you compel disabled individuals into accepting that assistance, that pathway into permanent supportive housing. That seems to be the big, gigantic dilemma out there. We can't force anyone, but we have to figure out how to compel people. And I think it takes the intensive, relentless outreach that's been mentioned here. One of the motions that came through at the advent of the formation of the committee was one that I co-authored with Mr. Wesson and Mr. Harris-Dawson in terms of best practices with other surrounding municipalities. I spent half the day in the city of Pasadena last week learning how they reduced their homeless population by half since 2011. Completely different scale, nothing comparable to Los Angeles. However, the big sort of what I gleaned from that was they stuck with a plan that they developed decades ago, have refined it through the years, but they've stuck with it. They've stuck with it. And I think that that's really what set them on the road to some success. Lastly, I think it was also you who mentioned land use for homeless, permanent supportive housing for the homeless, et cetera. I also think that clearly there's a shortage. You have vouchers, and that seems to be, you're in decent shape with the voucher system, which was described through the presentation. However, if we can figure out how to compel more people to accept the assistance that they need, what what are your thoughts on the shortage of permanent supportive housing, specifically in the city of Los Angeles?
Yeah, there is definitely a gap. I'm familiar with the work that the analysis that LASA did that was presented here a number of weeks ago that I think showed a gap around 9,000 or so units in the city of LA. As you talked about, you need to have a strategy that works, and you need to keep with it. That is the approach that we're taking, and so it's a huge leap to get to that end, but we just need to keep on putting together the resources to get there. You need a housing unit, you need a rental subsidy, you need intensive case management services, and that name, different agencies call it different things. We call it that, but you'll hear, different names for support services, intensive case management services, et cetera. We're looking to get from, our current, 1,100 to 2,500 by the end of this summer. So we're trying to make a big dent in that and to keep growing from there. But it's going to require that investment of resources to get there. We need the subsidies and we need the funding for the services. What Peter mentioned, the 1115 waiver, we're watching that very closely because we're looking at that as being an opportunity to help offset some of the costs that we're now sort of carrying completely for those intensive case management services. It's possible that will be a new funding stream, which will then allow us to grow that resource. So we will have more case management resources to match to the housing.
But you're going to need the product, and you need 9,000 more units. And I know Mr. Huizar and I have pending in the Housing Committee a value capture, and I'm hoping that we can get that through and get that going. It passed through the Plum Committee last April. So we're hoping that in this unprecedented time of growth with production of living units across the city, there's no reason we can't get in on the game right now with these resources to actually get in the business of producing toward those 9,000 units. And I would urge all of us to get behind that and get in the game of producing the housing so that we can not get caught flat-footed with this improvement of services and better coordination that we heard at the table today. Thank you.
Fuentes?
Chair, lots of things, so forgive me for the sort of scattered pattern by which I'm going to ask. But I don't want to lose sight of this. I think it was the Department of Mental Health that testified that there's going to be $19 million to be allocated for housing. Is that right?
Yes. 19 million additional dollars.
Additional dollars.
Because we had 115 initially, and now we have 145 million. Most of that's obligated, but we have 19 million that's not obligated yet.
And so is that, do you work with the City of Los Angeles and HCID through our managed pipeline to do that, or is there going to be a NOFA? How do we sort of get in on that?
So we have a process that's called an expression of interest, and when we open it, we set priorities on what areas of the county we're going to be focusing on and what types of projects. And when we have that process, the developers submit what's called a letter of interest, indicating that they have an interest in, and they have a project, and they, how much money they need. And that all comes to our Housing Advisory Board. And so Tim Elliott from HCID is on our Housing Advisory Board and has been for many, many years and has a great expertise. And he knows the pipeline, and he brings that information as part of what's being discussed when they discuss it. Like I said, HACLA's there on the committee, and we have other people that invest in housing, and then we have other stakeholders on the committee. So we do work very closely and on making decisions about what projects will be funded, and of course considering information that is brought from the city and about the pipeline, because that is important, because many of our projects, even if we fund them and they're not in the pipeline, they're going to be years and years out. And we have funding priorities that we use to make decisions, and those are what we use when we evaluate each of the letters of interest that come in.
And so, I think it makes an awful lot of sense for us to coordinate as much as possible, because the whole, idea of the pipeline is for us to be strategic from a City of Los Angeles perspective, and it would be a waste if we're not being strategic with you all as you're making your funding priorities. Is there a formalized table where that conversation takes place?
Yes. These people on the advisory, what we call our MHSA Housing Advisory Board, are appointed by our director, It's a closed stakeholder group, meaning they come together and make decisions or make recommendations to the department about funding decisions. And so we do meet monthly or council if we don't need to meet, so we meet as needed. We just opened our expression of interest, I want to say, in maybe October or September, October. So we just brought on, I think, 5 new projects. But yes, we work very closely with the city and have for years, because even after we invested the projects, things happen. And so we have to work together to figure out, especially when the recession happened, to figure out how to, make sure these projects keep going forward despite all the problems that they are experiencing. So we all work together closely to make sure that happens.
Got it. And so let me jump to something that my colleague, Mr. O'Farrell, sort of mentioned, and these are my words, not his. I think a certain amount of this, and I don't believe for a second that folks are comfortable at all in the situation that they find themselves. So forgive me for saying, I can't think of a better way of saying this, but it seems to me that for us to be able to incentivize some acceptance of services, in some cases, we do have to make a situation more uncomfortable. And so the different and many varied things that you all do are incredibly impressive. But how does enforcement come into play with any of your branches of service? I mean, how is it that we make and Peter mentioned this in our housing committee not too long ago, how do we sort of bring an authentic offer to these folks to hopefully have them act on it? I've visited various shelters, most recently last evening, and it seems fairly routine. The folks come in, they secure their property, we check to make sure that they're an HMIS or coordinated entry system, and then it seems that there isn't an uptick in service delivery after that. And I don't know what the answer is, but it seems to me that those situations are the most ideal, because we have, for a lack of better words, a captive audience for us to be able to make that authentic offer of service delivery. That's for the people that come in. For the folks that don't and refuse to come in, and again, I understand that we have to present a better offer, how do you weave into all of that enforcement to try to make a situation less comfortable so that they sort of see the value in the offer that we're making? And I understand it's the county, so specific to the city of Los Angeles, how do you interact with us and your service providers to authenticate that offer?
And I'll just have to be frank that the enforcement is not a tactic that we use. We've had a lot of success with the service providers that we're working with, who are so skilled and have worked so long with people who are homeless, that they are able to build a rapport and establish a sense of trust over time. It's very true that somebody's not going to, if you have been living on the streets for a long time, you're dealing with some really complex health and behavioral health issues, you've had trauma, you've had bad experience with different institutions, that it's going to take a while to build that trust and rapport. That's something that we're willing to invest in. So that is something, as part of these services that we're paying for the amount of time that the case manager needs to work with that client. And the case managers will go back over and over and over again over a period of weeks or months. And some of the great service providers that we work with, I've seen here today, with homeless health care and housing work and PATH, and there's others. Those are the providers that I'm talking about who are doing this work, and they're able to work with the clients and to help them over time, building a relationship to then accept services and to come into housing.
The question that I've got about sort of the interaction between, and I will stipulate to the fact that you're right, there are tremendous service providers out there, and they seem to be the inlet to all of the services that you all have that they could avail themselves of. How does that inlet work? I mean, so you've got, depending on which service provider area you are, you've got contractors that go out there. How do they sort of traffic cop or ombudsman, how do they sort of navigate their way to the respective agencies that you represent? and avail themselves of service. I mean, how do they do that? Is it as simple as the input into the coordinated entry system that recognizes that Felipe needs X, Y, and Z, and the effort is made to try to direct them to you all? Do you come to them? I mean, how do you manage that? How do your service provider partners manage that and facilitate that connection?
On the Housing for Health side, we have two main ways into our services, and a big one of those is the coordinated entry system. That is a really critical way to identify the most vulnerable and connect them to services and housing. Another way that we do it, because we operate a hospital and healthcare delivery system, is we have clients who are in our hospitals or in our emergency rooms who we know because we have them in front of us. We know they're homeless, and we know that they have a really complicated health condition. We've diagnosed it and we're treating it. So we accept those referrals directly from our hospitals as well.
I'll say on the DMH side, our department has contracts with over 100 agencies to provide mental health services. And so the housing resources that I talked about today, we allow all of our contractors to use those resources to help their clients. So they're serving people with mental illness, many of which are homeless, and they need to help them. So we, as a department, we manage and access and develop many resources that they can then access as they're helping their clients. So we have all kinds of meetings and things like that just to make sure that people are aware of the resources and how to access them and to constantly get the word out. So when they're working with someone who's homeless, they know what resources are potentially available to help those clients. It is a constant, we have to constantly re-educate many, because new people get hired or new agencies may not be aware, and just to make sure that our provider network is aware of the resources we have to help them do their job.
And for DPSS, we are still moving away from, but still traditional brick and mortar type service come to us. Now we have online access, but when a family is in crisis or individuals in crisis, probably internet looking through and finding services isn't the best. 211 is an excellent referral service for us, but we're also looking at different ways of trying to outreach. Maria mentioned the single adult model. DPSS is part of this, is actually looking at data, how individuals are extremely high risk accessing health, mental health, even the criminal system, to identify people at high risk that we can address their homeless need. In other words, we outreach to them and say, we understand you might have a number of needs, how can we help? It's a very small program. It just started a few months ago, but it's something that, again, trying to try different things, different ways of reaching out to folk. Now, and it goes back to Councilmember Rue's point about just multiple, so many programs. How do we connect? Part of what we're trying to develop too is this. So a homeless family might have multiple needs. They might not be able to reach out, articulate, know where to go. But if I'm homeless with mental health issues, but I need food, so I seek out CalFresh. What we're moving towards is making sure our staff know the multiple resources that are out there. So yes, we have someone, we know they're homeless, they've expressed mental distress, but now they're asking for food. How can we take that opportunity to link them to our if it's a family, our CalWorks program? How can we engage them in a subsidized employment opportunity? Basically trying to create the success outside of what might be the main need, but being able to create these successes. And to be honest, the way a lot of our programs work, it's word of mouth. So if we can get away from the non-successful stories and start having people share the successful stories, it's a different path of being able to get where we need to. But it does require quite a bit of information sharing and knowledge, and that's part of what we're trying to develop with our staff as well as our partners throughout our system.
I just have a couple more questions, Mr. Chair. On that note about sort of information sharing, are you all, to me the most ideal situation, given how complex and varied your service delivery is, and rightfully so because there are very complex issues, are you all on the same platform? So, what's ideal to me is that you'd be able to look up Felipe Fuentes and know immediately that, he's been on CalFresh, but it's our observation that maybe mental health department should be helping. Is it that ubiquitous, the technology? Because, Mr. Perez, you mentioned, it sounded like the coordinated entry system during your presentation is downstream a little bit. are you all on the same platform?
I could start and say not quite. Now we do have what we call the Enterprise Linkage Program, which is a database that was a pilot. It stopped, and we're moving towards getting into a greater integrated system this way. But this is about identifying if I'm accessing the county's health services, DPSS, and even the jail system. I know I'm accessing these various county programs. The county should look at the individual holistically rather than by department. We're not there yet. We had a pretty good pilot, and we are now working towards expanding that. But I think back to your main question. I come in and need county services. Is there one system that will show the variety of services that I'm accessing? We're not there yet. At least not that I'm aware of.
Yeah, there are a number of state and also HIPAA laws and regulations that, particularly when it comes to certain types of health and mental health information, that come into bear here on what sort of information we can share without client consent. So we are always searching for ways to be able to share as much information as we're able to do legally in order to provide the best service package and service connections for a client. And then we're also, what we do is routine for us is when we're engaging that client is to get that consent, which then allows us to do it. Where it gets trickier is before you've gotten that consent. At that point, we just have the information that is available to us as a single department.
Yeah. So I've got lots of questions, but I'll limit it to this last one, at least for the time being. So understanding, I think, that your service delivery is spread across the county and service provider areas, how do you prioritize service provider areas? I mean, is it an equal need across all of them? It's 8 service provider areas in the county. Do you divide? Is it simple math, or I mean, how do you know where the most need is and distribute your service delivery that way?
So from an outreach side, and our outreach is primarily Medi-Cal based, even though it expands beyond that. Whatever the needs are, we try to link to link the individual to our local programs. But we do use census data to see where the highest need is. On the CalFresh side, we actually started a pilot with the federal government to be able to identify where the highest underutilization of CalFresh program is. So there is some data, but obviously on the homeless side, it's something that it's based on census data. It's somewhat limited in what we do, but the resources, wherever they are, we would send outreach staff. A lot of what we do is actually depends on the local cities that request assistance. We'll meet that need as best we can, but it is not an exact science at this point, and we're trying to get there, but definitely being able to leverage the available resources is what we're trying to do at this point.
Yeah, some of our programs are, the resources are divided among the service planning areas based on the proportion of homelessness that they have in those areas. And so an example would be the rapid rehousing program for single adults who recently fell into homelessness that we're going to be launching in January. That's where the funding for those rapid rehousing slots are being allocated based on the distribution of homelessness in the county. Some of our services are also just based on acuity and who is the most vulnerable, getting back to that CES model, and matching that person to the housing and the services. So that one's not completely, a spa-based distribution. It's the most acute.
I mean, I just think of a sort of spa too, where I'm at, and I mean, it's a big. I think it might be the largest geography in your spa models, and the need seems just as high as sort of the geography. And so I just wonder, sort of how you do that, and how it is that we can bring to bear some assistance there. The chair mentioned a second ago, the level of dollars that go into your operation. It really makes the sort of the proclamations that we're making here in the city really pale in comparison. $100 million isn't going to do very much. I think the conversation needs to move to one where we're trying to be as collaborative and solution-oriented versus maintenance of effort, which it feels like without any strategic platform that helps us understand, one entry versus 7 or 8 Felipe Fuenteses that happen to be the same person. I think it's going to have to be something along those lines that are going to help us diminish the challenge. Until then, it's just a maintenance of effort, which is to say that there is no solution to it. But I absolutely admire everything that you all do and continue to do, and demand of us action if we can be helpful. Thank you.
Thank you so much. Members of the Homelessness and Poverty Committee, we'll start with Mr. Price.
Thank you, Mr. Chairman, and just to my colleagues who have engaging in this discussion and those at the table, appreciate your commitment and your service. Are there any estimates of what percentage of the homeless population is severely mentally ill? You know, those who don't want to get help, those who, you know, just taking off their clothes and wandering up and down the street. Is there some percentage of?
Well, the homeless count has consistently indicated that about a third of people who are counted through the homeless count have a mental illness. So that's about as much of a science as we have on that topic. I think I've heard people say that they feel like it's higher, but you know, based on the homeless count, that's the data we have. And again, that was the whole purpose of our discussion. But what do you think some of the tactics can be to get them off the street? What's the, you know, I mean, you mentioned you do initial outreach to them. You know, contact someone and they're adamant they don't want help. You know, or they say, come back, see me next week. You know, and I think it's. What do you do? I think Cherie, you know, covered some of that. That it really is just keep going back and trying to build a trusting relationship and having something to offer that people want. And I think that's what someone said that Peter Lynn had said to you all earlier, and we heard him say that too. It's something we were at this earlier today. And it's through that consistency and follow through. I've never done homeless outreach myself, so I can only say what I hear by, you know, the people that are out in the streets doing this, who I greatly admire, and that they say it's really through consistency and follow-up and doing what you say you're going to do and keep coming back that you can build the trust, because many people have been hurt by the system, do not trust the system, and do not trust our intentions when we're trying to offer something to them. And so it's through that process and building relationships and having something to offer that they want that I think we can help end homelessness. And certainly, we've all talked about the resources we have.
Ms. Funk, can we, for the sake of time, can your responses be as shorter as possible?
Of course. Thank you.
And I think a lot of people are going to ask the same question. Can you maybe talk about Laurel's law and involuntary treatment as well, but briefly?
So Laura's Law, also known as assisted outpatient treatment, is a new program the department is implementing right now, and it is a law that allows what's called involuntary outpatient treatment. I think people are familiar with involuntary inpatient treatment when someone is placed on a 5150, but this is a different, it allows involuntary outpatient treatment. And I have to tell you, I don't work with that program, so I don't have a lot of details, but it's a very specific law that has very strict eligibility requirements and a process that has to be gone through, and actually a court proceeding that is what will actually determine if the person is going to get involuntary outpatient treatment. So if you are interested in it, and anybody, they can always look at our website, and there's a way to refer people in to be assessed to see if they're eligible for that program. And I know there's a lot of interest in the community in that program because you know, many people see people on the streets that just look like they're at risk of dying because of their circumstances and their mental illness or maybe their physical health condition. And this is another option to help assist those people. So just to follow up on that, when someone is hospitalized for a mental health hold, and they're stabilized, and then they're released, right? Frequently with no real follow-up, no real continuum. And that's, I think that's a dilemma that we do face because of the laws around 5150s and hospitalizations. People cannot be held beyond the allowable period based on the law and whether they meet the criteria to be involuntarily held. If they don't, once they don't meet their criteria, they do have to be released. And what we've tried to strengthen is our resources to help make sure that people aren't discharged into homelessness. We have a ways to go, and I think we keep working on that. Is how do we make sure that we strengthen what we do while people are in the hospital, so we can make sure that they don't return to homelessness. Thank you.
Mr. Co-Chair.
Thank you. You know, just listening to everything, I'm still thinking that our approach, and I say our approach, our collective approach, both from the county and the city, it seems pretty bleak in how we're handling the issue of homelessness, because I often hear in the Skid Row area that an area I represent, and in downtown, all of downtown, we've heard that over a third of homeless individuals have some type of mental illness. And when they are in the street in downtown or Skid Row, the first interaction they come across when this mental illness begins to exhibit itself is our police officers, because those are the contact that you have with individuals in distress, or either through call or whatever it may be. So I'm thinking in terms of the county side, because it seems like, I just sit from the city side, this is all I see, and I see that it's all LAPD officers, that's city resources. On the county side, do you have enough mental health individuals out on the streets that could help engage in the situation with individuals?
Absolutely not. I think that's clear. We don't have enough resources. All these teams that I talked about are just like a new program, and it's definitely not enough, and we need so much more. And I think through the mini summit process that was talked about, that Phil Ansell is leading, and in partnership with the city, there's a lot of work being done to try to actually document how many more resources would we need to take what we know as best practices to scale. And then
and what would it take for that to happen? Does it take the leadership of the city to go talk to the county supervisor and redirect some of those dollars, or what would that take to happen? Because earlier it seems like we were very happy that we're getting all this new money to do different things. It seems that money is targeted and not necessarily for the type of first interaction that these individuals need on the streets, and that's where I think the money should be. I'm new to this area. I'm still learning a lot, but it seems to me the best dollar spent for ourselves is we get more mental health experts out on the street.
I think the opportunity is coming, because out of the mini summits and in collaboration with the city, there will be recommendations that will go to the Board of Supervisors and, my understanding, the City Council, presumably, or we're hearing on the same day, which is wonderful, to hear recommendations and actually then to talk about how do we get the resources to make these things happen. And so I think through that process, we'll see what comes out of it. I don't know if you want to talk about the new C3 program. That is another, I don't know if you want us to go there, but that's another new project in Skid Row area to really try to be more strategic in outreaching to people there. That includes mental health and health services and other people to try to more strategically do outreach and help people in Skid Row area.
I think my office has been working with your office on the C3 program, where we are breaking up Skid Row into 4 different quadrants, hiring full-time staff, social workers, 5 per each quadrant, 20 people a day on Skid Row that will build the trust, the relationships, as you mentioned, to eventually get people to commit themselves or get them the services they need, whether it's mental health or anything else. But I think that's just a start, and I think it's something we should have been doing a long time ago. But it's a start, and hopefully through our recommendations on the county and the city, we will be doing more of that, but not only pilot, but throughout the city, and continue to put more of our resources out there. And the other issue is that, I do think there's a huge imbalance right now. There's more officers who come in contact with people with mental health issues rather than mental health experts. And we have to balance that out, but we can only balance that out with the county's assistance. And when we do have that interaction, because of litigation, because of our laws, to commit a person, whether before they commit harm to themselves or to others, they have to commit a crime. It appears, and then that's when we throw them in jail and they get involved in the criminal justice system. And so that itself too, I think, is going to. I would ask for a long-term research into the legalities of when we can and cannot. I don't think we fully have a handle of that in terms of how we are approaching it, both at least from the city side with our officers, and we should coordinate with our mental health experts as to how we could better approach individuals and, commit the people that do need to be committed to the fullest extent of the law. Usually we wait until they commit a crime and then they get committed, but they get committed to our local jail, like a county jail, like I said. So that itself, I think, needs some legal analysis and research that could help our recommendations in our report as to how we could better refine our approaches out there, both on the city side and the county side. Because as Councilmember O'Farrell started off with, this is really the crux. When I talk to my constituents and work with them, it's the issue of mental health and how we get over a third of our homeless individuals the attention they need, which has been highly lacking. And it's only going to come about if we create a better balance in terms of the contact that these individuals have and more with mental health experts rather than law enforcement.
Mr. Cedillo?
Thank you. Well, thank you for being here. It's great that you're here. We really appreciate you. So much of the attention on homelessness comes to the city and to the city council and the mayor. But the fact of the matter is every day, each and every day, you as professionals are working with those who are homeless and challenged either with substance abuse or mental illness or the dual diagnosis, foster youth, these homeless families that you mentioned, et cetera, and yet everybody looks to us and we walk around feeling like we've got to solve a problem for which we don't have legal jurisdiction nor fiscal capacity. And so we welcome you and thank you for joining us in this conversation. Let me follow my lead of my colleague and speak randomly about some of the questions I have. One of the things that you said was that people should not be discharged into homelessness. And so what are some of the things that we can do or need to be done with respect, for example, foster youth, right? What can we do to make sure that every foster child that leaves has their Medi-Cal, part of the ACA, that has some housing voucher, has a system in place so that they can enter society, so that we don't end up seeing them on the street 6 months later. We know that 50% of them will be on the street 6 months later, and then later on many of them will be incarcerated and then have this most challenged life. Are there things that we're doing today that we weren't doing before in terms of enrollment? Yes.
Sure. About foster care youth.
Yes.
Their Medi-Cal eligibility, well, when they're released from DCFS or through, if it's a probation camp, Medi-Cal should already be engaged with Medi-Cal through the probation department, and that Medi-Cal should continue, I believe, till the age of 26. So that coverage should be there. Now, are there instances where there's gaps or where there's some sort of just lack of knowledge that there's coverage? Yes, and we got to do a better job of making sure our youth are informed of that. We are working on, we do have a number of subsidized employment programs that target youth. They're small scale, and it's something that we're working with our Department of Children and Family Services to ensure that the opportunities are not only made more widely available, but that they're better known. I think that's part of, again, a bureaucracy as big as the county, the kind of disconnect in the knowledge. So we're doing a better job of making sure those resources are out there. In terms of discharge, I think my partner, county departments, as well as DPSS, have a resource center at the Men's Central Jail. So when individuals are released and if they need Medi-Cal or any of a variety of services, we try to engage them. It is up to the individual to reach out to us, but definitely the sheriff staff encourage individuals share information about it, about the various services, and we try to engage them at that point as well. That's not those three efforts are not the answer to your question, but it's part of what we're trying to do.
Okay. You know, particularly the youth, I recognize other challenges with adults coming out of the county jail, but foster youth, I mean, we're in charge of them, and so it seems that we would be able to mandatorily ensure that they are signed up for healthcare services, mental health checkoffs, and then the resources that you talked about, individual homelessness, that those resources are there at the front end, that we're really accelerating those efforts at the front end to make sure that they're moving in from foster care or from a camp into their own apartment, their own house, their own roommate, their own situation, that makes sure that they're not headed to the streets. Are we doing that? Can we do that?
I can tell you that is definitely a priority of the board, but I think the people at this table are not the right people to ask the question to. At least I know I'm not from the department. I know there's a lot of collaboration between our Department of Children and Family Services, Probation Department, and mental health, and there's a lot of collaboration because of that very issue, but I'm not at the table, and I think they would probably welcome you inviting them if you want to have, I don't know if you know anything more about that, because I don't.
Anything additional to add? No.
Yeah.
I'm sorry.
Okay. So there seems to be, you talked about Laura's Law, there seems to be for many families such an incredible distress where they have people who are, what is it, 5150? Who, I mean, is this the time for us to go back to the Latterman, Petrus, and have a discussion about involuntary treatment of individuals given the intense, we've got over 1/3 who are on the streets.
I think
we have trouble trying to bring them in.
I mean, I think that discussion has continued for years, and I think, you know, there's two sides. There's the side of discussion of people's civil rights, and there's the side of the families and other loved ones, or people just seeing people in distress, especially on the streets, and what can we do to help them and wanting to help them. I do think the Laura's Law, or assisted outpatient treatment, is one answer to that, and that is a new option that LA County, you know, is implementing, and to see how that goes. But again, even with the assisted outpatient treatment program, our first approach is trying to engage them in voluntary treatment. And if that, there's a whole process that has to be gone through before they'll go before the court to try to get involuntary treatment. So that's a new program, and I think, you know, in a year or so we'll see how it's working and see if it is helping some of the people that you're talking about, that, you know, that people are very concerned about needing services and treatment that aren't wanting that at that time.
And then finally, if I don't want to, it's hours late, NIMBYism, right? What are the things, I've got a project in my district, 3 city parking lots. We're trying to build very low affordable housing, some affordable home ownership, various formulas to move people who, I have people in the Arroyo who could be living there. And then I have NIMBYs who are blocking these projects, abusing the laws of CEQA, which were designed to protect our environment, not to protect NIMBYs. And I've got 3 or 4 projects right now, and there's a cadre of people who go around to all the hearings, to all the planning committees, to every opportunity to block our creation of housing, and the whole range from low income to market rate, to block housing in our city that would be the housing first option for many of these people. What are your thoughts on that? What can we do about that? What are we doing about that?
Well, last Friday I helped facilitate a panel that actually Council Member Bonin was on, and this question came up. And I thought, you know, some of the responses by the panelists I thought were right on target. And one is, you know, why do people do that? What is that about? And some of it is about fear and a misunderstanding and stigma about a misunderstanding of who the people are that could be living that housing. And there was someone on the panel from a faith-based church, actually, in Santa Monica, and she talked about, you know, we really need to work with our communities and help educate them and help them meet the people that would be helped through housing like that. And I do think, in my own experience, that when people who oppose things that they hear and they think, oh, this is housing that will be built for people who are low income or people who are homeless or people with mental illness, there's a lot of stigma and misunderstanding of who that population is. And that when they start to meet people who represent that population and see that there is a human face and hearing their stories, I think that helps turn people's minds in those situations. And it's hard work. We've had projects that we tried to fund through our MHSA housing program that we had the developer pulled out because the community didn't support them. So we don't have, you know, another housing project in the community. But I think if we work together and engage our partners, including the faith-based community, in helping to educate the community and other leaders in the community, or respected people, to help support the things that we're doing, that can make a difference.
Anyone else?
I echo what Maria is saying. the work that the work that we do is not new development. So we are assisting people, some of it into housing that's been developed by others or existing housing in the market. But we do come across this issue because we are using market rate housing, and we are working, with landlords or property management who may not be familiar with providing, renting a housing unit to somebody who's just come out of homelessness. And so we actually do what Maria's talking about and talk about who the program's going to help and how it's people who are in their community who are going to be coming into housing. And we also are there as a resource. So one of the things that's been very helpful for us is that we maintain a relationship with the landlords and the property owners, and they can come and work with us if they're ever having any client issues. I know that's different than what you're talking about, but it gets back to that that sort of human connection and putting a real person to a face to the issue that we're talking about, and that often opens doors.
And then finally, the last thing is on the, what can we look forward to? We have an incredible police department, but they're asked to do jobs that's not theirs. They're not mental health experts. What we need are mental health experts and substance abuse experts and healthcare providers to deal with people who have those needs. And the scenarios, as Mr. Weezar mentioned, they're not only not help, but and sometimes they exacerbate a situation, the presence. And so how do we make sure that we put more providers, mental health, substance abuse, healthcare professionals, EMTs, et cetera, out in the streets, boots on the ground, interfacing with the homeless community so that we can avoid the types of tragic situations we've encountered in the past.
I can say, although I don't work in this area either, but I do know the department has a lot of law enforcement partnerships with LAPD and other law enforcement teams across the county where we work with them directly, responding to situations, and I also know that we are expanding those teams in the next several months to have more of a partnership. So again, if you have interest in testimony specifically about the work that's being done, we can ask someone from our department who is directly involved with that. But I can say that there are many partnerships with LAPD that already exist, and there will be an expansion soon.
Thank you. I'm going to, for the sake of time, I'm going to try to sum it up in a minute. I mean, I could talk on this topic for hours, but this is a very good first discussion. And having worked in the county Board of Supervisors for 6 years, working with many of you, and then 6 years again on the provider side for the second largest mental health homeless provider in LA County, I got to tell you, colleagues, what we've talked about today is just the tip of the iceberg, as you guys all see. And I just want to say, what Councilmember Farrell and many of the other council members talked about, we said 1/3 of the homeless population is diagnosed mentally ill. But I think it's also well known that about another third is just undiagnosed. So you are right in saying that the majority of our homeless population has another disorder. And what my goal is for the Health, Mental Health, and Education Committee is, as mentioned before, and I think a lot of you guys talked about it, is trying to create an inventory. And Councilmember Fuentes talked about it before when he started listening to all the different housing pots of money that are in existence. And right now, everybody is trying to work together, but the short answer is it's the provider. It's the actual agency or the developer when they're going after these funds. We try to coordinate between the city and the county all on their own, but it's the provider who has to go and apply for all these different pots of funding separately. Same thing for the individual, whether they're incarcerated or whatnot, or whether we do outreach. It's that individual who happens to get in one of these systems that gets integrated. So it's very important when I talk about an inventory of all of our resources, all of our programs, and it's about what the city could do to enhance or augment what the county's doing, and also plugging in the holes where what they can't do. And the solution to this homeless situation is going to be very interdisciplinary, and it's very complex. We always talk about housing, which is a crux of it, but we got to also understand, we're in a democracy, we're in a society that values liberty and freedoms, and individuals have the right to be homeless. So we have to keep that in mind, and prevention is huge. Those who are most at risk, foster children, domestic violence victims, I mean, you name it. We also have to focus on prevention. And many of my colleagues, especially Councilmember Chairman Huizar, and I believe some of the other colleagues talked about other avenues. We also have to look at existing laws. That's why I asked about Laurel's law. And there's other laws or other avenues of maybe possibly extending parental rights for those who are mentally ill from 18 to 26 for transitional age youth. I mean, these are highly controversial topics, but it's going to be multi-pronged. And this is a good first discussion, a lot more to have. And I thank the panelists here today because I think a lot of the questions we threw at them is actually above their pay grade. But thank you so much for fielding as many as you can. We continue to work together. And when I say above their pay grade, it's about, and a lot of other council members asked, it's about sitting down with the Board of Supervisors and asking them how we could work more collaboratively together so the city could augment the county and plug in those holes. Thank you so much. We are way behind, but we do have one more item on the agenda. And if we could have the representatives from St. Joseph Center, I believe it's Dr. Adams, Downtown Women's Center, Anne-Sophie Morissette, Path, Lakeisha Childers, and Housing Works, Molly Lowry. If you guys could come on up. Because of the time, we're going to give you guys a minute each. Come on up into the table. We're going to give you a minute each to talk about exactly what your agency does, and then we're going to ask one question to all of you, which is basically going to be, what are some of your barriers to providing service to the homeless community? What are some of your, or you could, when I say barriers, it could be to getting funding, to getting support. So what are your barriers, okay? So 1 minute each to talk about exactly what your agency does, and then we'll go back around and you guys can answer that question.
And particularly barriers that the City Council has some purview over, so it's something that we can, hopefully respond to. Again, we apologize, but in the interest of time, we have to truncate it. I know at least one of you has a play to make with a date that's not going to wait, so hopefully you'll bear with us.
So we'll go my left to right.
My name is Molly Lowry. I'm with Housing Works. Housing Works is a supportive services provider. We do outreach engagement to the most vulnerable chronically homeless folks throughout the county, and we help them locate housing in scattered site housing. We use housing first strategies, so we place people into housing and then provide them supportive services for as long as it takes, whatever it takes, to help them hook it up into whatever treatment and care they want and need and have access to.
Good evening. My name is Lakeisha Childers on behalf of PATH, People Assisting the Homeless. We are a homeless service provider. We provide rapid rehousing, permanent supportive housing, and general supportive services to all individuals, families, veterans. We are a countywide and a citywide provider, so we're in all of the spas, providing any level of case management that's necessary, intensive case management, linkage to services. But we are essentially a homeless provider providing wraparound services.
Hello, my name is Dr. Felicia Adams-Kellum. I'm the Executive Director of St. Joseph Center. We provide services on the west side of Los Angeles and also in South LA. We provide housing and feeding and homeless services to both individuals and families. We are the lead service provider for the coordinated entry systems of single adults and families on the west side. We have a whole host of programs, but we are an integrated service entity, which means we do Department of Mental Health services, DHS services. We have physicians on board as well as mental health specialists. So we do street medicine and wraparound services for the homeless.
Good afternoon. I'm Anne-Sophie Morissette from the Downtown Women's Center. We've been based in the Skid Row area for 38 years now. We are a provider of permanent supportive housing. We have 119 units with 2 residents here in downtown. We also have a dedicated women's health center, the only of its kind in the downtown area, as well as a day center that sees about 200 women come through its doors every day. In addition to that, we run a workforce development and job training program. We also have a social enterprise with 2 storefronts also in the downtown area. We've partnered with many of the agencies you've heard from today. Most recently, the Housing for Health program. We've just signed on to provide housing to 95 women over the next 3 years in partnership with the Department of Health Services.
Good evening, Veronica Lewis. I'm the director of the Homeless Outreach Program Integrated Care System, HOPICS for short, which is a division of special service for groups. We primarily serve Service Plan Area 6, South LA, and we provide an array of services and are actually funded by or closely connected to everybody that was sitting at the table in the panel, in addition to the Department of Public Health. We are the lead for the coordinated entry system for SPA 6, and in addition to that, we provide wraparound housing services for individuals and families. We also are one of the leads attached to the Family Solution System as the crisis housing provider. We provide community mental health services, and we are the SPA 6 Community Assessment Service Center, which basically is the way in which adults access substance use services funded by the county. We're the lead for SPA 6. We're also in the victims' rights space in terms of being one of less than 10 trauma resource centers in the state of California. So we're providing trauma-related services to victims and witnesses of violent crimes, which we know in South LA is unfortunately a high number. And we're also an intensive case management service provider for the Department of Health Services. And so I look forward to this conversation because I have a perspective in many of the different spaces that we're talking about and know where they are connected and where they're not connected. So thank you for having us.
Thank you all so much. So really quickly, and you all can take it in whatever order you see fit, what are the main barriers or pieces of assistance that you think the city can provide with the various departments and forms of interaction that we have with your work?
Well, I think the systems are there. We are developing systems as we speak. And you heard about the systems of care, the coordinated entry, the homeless family solution system. It's scale and resources to provide the staff needed to do the work. In just the last few weeks, many of us received new contracts that need to start tomorrow morning. And the question is, where are we going to get the staff? How can we scale up in a way that makes sure we have an effective program? And the big elephant in the room, I think, is also housing, making sure that we have the housing available to get people off the streets, whether that's short-term, interim, or whether that's permanent supportive. So I think that, in a nutshell, is what we need. What you are doing now is growing the resources available, routing those through LASA and into the coordinated entry system, I think is a fabulous idea. We don't have a lot of time. Those systems are in place, but we do need to scale them, and we need really great staff to get it done and do whatever it takes. I think in addition to that, there's a couple of areas. The reentry or forensic population needs to be considered strongly. So even with some of the systems that we have in existence right now, that population, because of some of the tools that we're using, are being left out for a variety of ways, in a variety of ways. And so I think we need to pay special attention to the subpopulations, especially those that are vulnerable. Also, some of our systems, we need to spend more money and more time figuring out how to coordinate for families experiencing domestic violence. And so while the systems are great and I'm a part of both of them, I think that the reentry and the domestic violence population needs special consideration. The other thing I think as we have the joint committee in front of us, there's not a connection point right now really between the substance use provider world and homeless services, and I'm in both of them, so I can see that. And so that's a huge gap. Obviously, when people come into our substance use system, we know if they've come from a home or not, and so there needs to be a quicker way of identifying people before they're released from treatment so that we can start working with them to have a stable place to go when they're done with their treatment. The other thing I want to say is that there's a lack of...
I'm sorry, let me just stop you because I want to be clear about what you said. When someone goes into substance abuse treatment, when they're released, you don't necessarily know whether they're going back into the homeless population?
Well, there's a case management side of substance use treatment, but there's not a connection point. I can tell you right now, because we're one of the casts that I described, there's one in every single spa. Most of them don't know what coordinated entry system is. There's no connection to the service provider network, and there's a huge service provider network. And so if they were connected to the system and we figured out a way to have screening done while the substance use and medical screenings are happening, the screening for homeless services is done at the same time, we can start working on stability for those people once they're released instead of working on it 2 days before they're released, set to be released.
And there may be a model available in the integrated mobile health team space that you may have heard Maria Funk talk about, those integrated teams, which do have substance abuse and mental health specialists and physicians on those teams. And in our case, we were required to bring substance use on board into that team. So that may be a space where we can begin to bridge and see how that collaborative conversation can be had.
And Mr. Chair, and that's why, and actually thank you for reminding, that's the reason for the whole item number two. And the subsequent panel talked about the Medi-Cal and drug waivers that are happening. It's a response to the whole Mental Health Parity and Addiction Equity Act from 2008. And that's going to be a whole, and what she's talking about in the end is, historically, everything's been underfunded, but alcohol and drug has been least funded. I mean, the least of the least. But now with this whole new equity and waivers, there's going to be a whole new source of pot of monies, which will be able to address all this. And it always boils down to a lack of resources, lack of money. And now with all these new waivers that are coming up, they're going to be able to apply. So they're going to be able to acquire more staff. And where alcohol and drug clients are going to be at parity of those who have mentally ill. I don't want to say if you're mentally ill, you have the red carpet treatment and you get all the services that you want, but you get much more available to you than an alcohol drug client. But now we're going to do that parity, and which is a new funding stream that everybody's excited about.
Yeah, that's the issue I want to address in terms of a barrier to being effective in terms of housing folks and helping them keep housed and take care of their needs. There is a huge gap in access to mental health treatment and substance abuse treatment in this county. To get into treatment, I can elaborate, we don't have time, is very, very difficult and sometimes impossible. So even when you've got your treatment-resistant folks at the door ready, the door's shut. And that's not working. It's making it very difficult for us to help people get housed and stay housed.
It'll be interesting to see if the C3 models, and we don't have C3 model on the west side yet, and I know it's starting downtown, if that can be the beginning of the scaling up of these integrated teams beyond what we've been doing in mobile health.
Just to echo what Molly was just saying, that's certainly the case for our women. We serve unaccompanied single adult women, most of whom are older women suffering chronic health problems and mental health issues as well. And while they're able to access our services, we find that other services just aren't geared towards that subpopulation. I shared some data with you. Over 2/3 of the women we serve have suffered some form of violence, abuse, child abuse, sometimes all three, and the services just aren't trauma-informed in the way that women's only services are. And regarding the lack of housing units, that's also something we know all too well. Last year, we intaked about 500 women into the coordinated entry system. We personally only housed about 60 to 65. So we're finding that even though we're able to intake a great deal of women into the system, the units that would then complete the process or start the process of being stabilized in housing just aren't there. The same with our veterans program. We're able to provide HUD-VASH vouchers to women very quickly. Sometimes in just a week, we're able to secure a voucher. The real challenge is then finding safe housing, affordable housing. Often our veteran women have young children with them. So the barrier really is that the units are not there.
So I have two more things to say, and I'll be quiet. So in terms of the landlord piece, one of the things we're seeing in South LA is there's a lot more fair market rate renters coming in, and landlords that traditionally have worked with us on our rapid rehousing programs or long-term subsidies are saying, no, because they can get more money and they reduce the risk. And so one of the investments we need is the ability to further incentivize our landlords. And so one of the things we're looking at in our community is that can we find resources to do landlord mitigation to say, we understand you're taking a risk, a perceived risk, and so can we have a property damage or eviction fee or something like that mitigation fund, so that's one incentive. The other thing we're looking at is some money to try to have a 24-hour hotline for landlords. We know we all know crisis intervention well as it relates to mental health and other conditions, but landlords sometimes have 911 calls they need to make that affect other tenants and things like that. And so if you look at investment in terms of incentives beyond the affordable housing and things like that, we need some dollars to say, we can't pay for everything, but if there's damage beyond the security deposit or something like that, we have a mitigation fund. So that's one thing. The other thing I want to say is, once again, although I'm involved in both the single system, coordinated entry system, and family system, which we know families are defined as children, there are some gaps. And so there's a lot of people living on the street as couples that don't have children. And also, there's some people that fit between needing a long-term subsidy, such as Section 8 or Shelter Plus Care or things like that, and needing a short to medium-term intervention that's less than 12 months. There's a whole bunch of people that fall in between that because they're on general relief or because they have income that's not sustainable and it's going to take a longer amount of time to get them stable. And so greater flexibility in terms of not boxing off everybody so much so that if you fall between the box cracks, we can't help you, is something that we need to look at. Because as we're developing these large systems, there's still segments of people being left out, and not everybody is appropriate for one or the other. And so that's a huge consideration that I hope that you'll think about.
Yeah, and I think those are the holes that we could try to assist in plugging. And just to respond to the Downtown Women's Center colleagues, that's why I did introduce a motion to help fund domestic violence, because victims of domestic violence have the highest rates of becoming homeless. And as your own statistics show, women had that victimization. And that's why we need to fund domestic violence programs, as well as everything else. And just to piggyback on what Molly was talking about and what you're alluding to, Councilmember Bonin's not here, but he's been a champion of Section 8 vouchers. And that's another problem. And he's been working to lobby with the federal government to increase those rates, because sometimes it's not enough, we put them back into the same situation where they were trying to get them out of, especially if they suffer from mental illness or alcohol and drug addiction. Yes, one thing that we can do, since we were very limited on time, if you guys could list a lot of those barriers and impediments that you have and suggestions and ideas, you could send it to our offices, and Chairman Harris Dawson and myself will compile this information and share it with all our colleagues, and all your contact information as well, so all the other members could reach out to you on an individual basis. But I want to let all my colleagues know that the individuals in front of us is a small subsection of a much larger community that's been doing this wonderful work. And
for the good of the order, are there any questions or comments from any of our colleagues? Mr. Price?
And again, I thank you for your commitments and for your work all around the city. I'm especially interested in SPA 6 in the 9th, but I think this also is applicable citywide. Again, what's the best way to identify and have outreach done to the severely mentally ill? Do you, I know they're identified. You may have a team of folks, and you're going into an encampment area. Someone says, no, I don't want any help, and they continue playing with, some object, and you just sort of move on, or you make a list, or you come back to them. I mean, what's the reality in terms of the scope of the problem of really getting back to folks who have issues?
Well, it's a good question. When St. Joseph Center started this work years and years ago, we weren't doing mental health, and it wasn't integrated into our outreach work, and it is now. And there's tremendous success when you integrate mental health services and health specialists. So many items or things that you mentioned is exactly what we have to do. You go into those encampments and you sometimes take a physician. Sometimes you clip toenails right in that encampment, and you get someone to begin to see something they haven't seen before and experience a sense of caring that's new. And then you come back the next day and the next day. We have had teams that have taken a month to complete an assessment. And eventually, we get people off those streets. We've done that in Venice, we've done it in Santa Monica, and we're doing it in South LA. But it's tenacity, it's having, and it does take a higher level skill set among some of those team members to really get to the people who are the most severely mentally ill, because we can get them off the streets as well. And we have a 93% success rate of keeping them off the streets. That takes retention dollars. That is very difficult to do. So we're still sending mental health specialists into the apartment, and physicians and nurse practitioners into those spaces to keep people housed.
But I think it's also about redefining outreach, engagement. What does that mean? Because a lot of the purview is that it's a one-time or maybe two-time or maybe three-time encounter, and so that's what Felicia is talking about. And a lot of the dollars are coming from the mental health side right now, but I think that just as a system, as a regional system, we really need to look at what does outreach mean, because the traditional way does not work, and we know that there's people living on the street that don't want to go into the shelter system for very valid reasons. And so until we find, I heard somebody say earlier, a better solution or an alternative, we need more resources to do, I'm not going to call it outreach, to do field-based engagement or field-based navigation.
Right, and the list that you mentioned, the service registry work, or whatever we want to call it, where you're going in and we do 3 or 4 days of really assessing who's there. Before we throw a lot of money into a space, I think it's important to know who's there, how many are severely mentally ill, how many are highly acute, and then you bring the resources to bear so that you don't get people really enthusiastic and thinking they're getting it off the streets and then they're left behind. So we think that's also very important.
I just want to give it just a little different spin, because I think when we talk about you have to be highly trained, highly skilled to be able to assess whether somebody's mentally ill or not, I believe that engagement, outreach engagement, involves creating an authentic, trusting relationship, human to human. Whether or not I can diagnose that person as schizophrenic or not isn't the issue. My issue is helping them move towards housing where they can make their lives start to work. And if a mental health issue is part of making their life work, then hooking them up with treatment when they're ready and trusting that that treatment's going to actually help them and not hurt them. So it's pretty much the same thing that's being said. It's just taking this thing off that they have to be professional mental health people.
Yeah, well, I don't think it has to be either or. I think what we want to propose is an integrated team so that you have the resources to bear in that space and in that encampment. And you're going to find
to actually
people,
offer them.
That's right. And
yeah.
I think you're also speaking to the peers that are very important and often much more affordable. And they can take people often from the encampment into housing as well.
Mr. Huizar?
Thank you. And yes, I think there is space for some more field engagement, but at the same time, we should acknowledge that we don't want to let that be a substitute for continuing to allow people to stay on the street. I mean, I think no one should, we should not just continue to do that field engagement thinking that that is an appropriate place for human beings to be is in our streets. I mean, the ultimate goal is to house them, right? So that's just a side point. But my question is this, is just in your experience, for those individuals who need support for mental health in housing, what's the capacity that we have generally in the city of LA? I mean, I don't know if you know this or just, what you see anecdotally, and the need. I mean, we got some numbers in different types of housing that we need in a previous committee meeting, but I don't think we got the answer to people who need mental health assistance, and that connection is there, right? The capacity, the space. What's the gap? Any sense? Have you guys read anything or seen anything, or just in your own experiences? That's something we need to look at our staff. I think.
And just if my co-chair doesn't mind, if I could add a little bit to that question. Operationally, do you go out and talk to people with the knowledge that you don't have some place to put them, or do you stop going out to talk to people once you run out of space? And then how often does that happen?
Yeah, that, quite frankly, when coordinated entry system first started, that was a very healthy tension that we had when it was like survey. We were like, wait, because in many cases there have been registries, there have been previous activities, and people already had a distrust for being asked questions and then there's no result. And so I would say we continue to struggle with that. No, we don't stop completely, but it is something that comes up because we do then face client retention issues. When housing becomes available, we can't find them and they don't want to hear from us because we've talked to them so many times without offering something in a reasonable time frame. And so I think I can speak for Spot 6 and say that that's a struggle for us, and that still continues to be a tension on. We know we need to know who's here, we need to know the need, we need to know the levels of vulnerability, but at the same time, how many times do you engage folks without having a real-time solution? And so we continue to work to figure out the best way to address that.
And I know this body has been and has shown support of rapid rehousing, and I believe that we can pair rapid rehousing with vouchers for the very point that Councilman Weezer said is that we do need to get people off the streets, and oftentimes they will not go into shelters, and sometimes we can get them into single room spaces while we're getting them ramped up and leased up for housing. I mean, housing first is about not needing to go through all the steps, but there are people that need to go indoors swiftly, particularly when they're very vulnerable, both from a health perspective and mental health situation. So we need a full complement of resources so that we can pull people off the streets immediately. We often use motel vouchers and things of that nature as bridge, and the movements that are happening here in this chamber are part of that. So you can give us the resources to go into those encampments and figure out who's there and figure out who needs what. And when you grow our resources and our options and flexibility, we're able to do a better job.
Thank you. And I think for our planning purposes, Mr. Chair and committee, as we develop our strategic plan, we have been developing more information as to the types of housing that the City of LA is building and where are those gaps and how we should, where are our future investments for the types of housing we need. We are, but we want to also acknowledge that as we're building this housing, how many, what type of housing is available for people with mental health needs. Even if we say we're building permanent supportive housing or wraparound services, we have to ensure that those include some type of mental health assistance, or at least help fill that gap, identify what that gap is, and at least know that when we're investing in future dollars through our strategic plan in housing, we're providing funding for those types of services. And that's we didn't get that information in our housing reports, but we'll need that as we move forward from our CAO or CLA. Thank you.
Particularly for transition age youth who often have mental illness as well, we know, and there's no space for them. And as they age out of foster care, it's a deep concern that they are the ones falling into homelessness and chronicity eventually.
Mr. Chair, if I could just share my experience, because working in this space before, just to answer your question, all permanent supportive housing, when they first build it and they're about to take applications, there needs to be an actual process because they get flooded and get filled like in 10 minutes, all the slots. I remember for the mental health hospital I worked for, there was a unit that we were a partner, a complex that we were a partner with, and they had 49 units with 19 dedicated for mentally ill. We had 85 applicants ready for those 19 units, but the other units are available as well. But just for our agency, one agency, it was 85 applicants for 19 units.
Thank you. Excuse me. Thank you. And I'd like to thank the panel for your expertise and your display of knowledge and really being in the trenches. Very refreshing, very honest, very authentic, and for your frankness. And I think that the big reveal for me was a deficit in terms of once someone's gone through a drug treatment program, that there's often, first of all, it's hard to get them in, and second of all, there may not be a safety net to keep them drug and alcohol free. That simply sets people up to fail, which is the worst thing you could possibly do. And I think that we need to go to the heart of the matter on this, because no one wants to unwittingly participate in a process in your chosen profession where, because of the lack of resources, we're actually making the problem worse and harming people. But to me, that's the end result. Unless we can figure that out, that's an enormous problem. And I hope that we can explore that and definitively identify the resources and the solution. because without that, it's kind of like raising a child halfway. You just can't do that. You've got to have the entire package, and I think this is one of the sources of the matter here, because as I'd mentioned before earlier, these encampments are just rife with just incredible depravity based on disability because of addiction issues and mental health issues. So I would love to help in any way I can help figure this out. So thank you.
Excellent, and thank you so much to our panel and the folks who hung with us throughout this hearing. Mr. Clerk, if there is no objection, we'll continue items 1 and 2.
Could I just also thank the panel as well? Thank you and acknowledge you, because what the city and the county is trying to do right now and trying to collaborate, I want to acknowledge that you guys as agencies are doing it. You're going through the alphabet soup and all these funding streams and trying to piece it together, and you're actually delivering a holistic, collaborative approach in the microcosms, and we're just trying to upscale and do it city and countywide. Thank you. Thank you so much.
Excellent. Thank you, and with that beautiful summation by Chairman Rue, we're adjourned if there are no other objections.